Hello everyone. Today we will discuss about obstructed labor. Obstructed labor is an important topic in obstetrics, and you will often find this not just for the sake of theory exam, but whenever you are posted as a medical officer or even as an intern in the primary healthcare centers in the community medicine department, you should always be able to take up a position and a decision when it comes to delayed labor pain or any kind of obstructed labor. So it is very essential to save the life of not just the baby but also the mother. Obstructed labor is a condition in which the presenting part of the fetus cannot progress through the birth canal despite strong and adequate uterine contractions. The mechanical barrier prevents normal progress and the uterus responds by contracting more forcefully, ultimately threatening the safety of the mother as well as the child. Major cause of maternal and fetal morbidity. So, what are the stages of labor? The first stage, which is latent and active, it is a physiological process wherein there will be cervical effacement and dilatation. The usual problem for the obstruction is cervical dystocia, rigid cervix due to scarring or early malpositioning. So the clinical implication will be prolonged latent or active phase resulting in failure of dilatation. When you take up the second stage of labor, which is usually descent and expulsion of fetus, here because of contracted pelvis, malposition, transverse arrest, malposition, cephalopelvic disproportion, this will result in failure of descent despite strong contractions. So, pelvic abnormalities like contracted pelvis, which might be due to rickets, osteomalacia, or malnutrition, results in narrow or mid pelvic outlet causing cephalopelvic disproportion. Pelvic deformities like trauma, congenital anomalies, or scoliosis can result in irregular pelvic inlet or outlet leading to the arrest. Then spinous disorders like kyphosis or lordosis resulting in altered pelvic axis resulting in ineffective descent. So the soft tissue obstructions like cervical fibrosis from previous surgery, large pelvic masses like fibroids or ovarian tumors, edematous cervix due to prolonged labor, full bladder or rectum, or even female genital mutilation scars can result in obstruction. Fetal factors like malpresentation resulting due to bro presentation, face presentation with mento posterior position, transverse lie or shoulder presentation. Then malposition like persistent occipito posterior or deep transverse arrest. Coming to the fetal size or anomalies, macrosomia, which is usually common in diabetic mother or postterm, here the shoulders or the head cannot negotiate with the pelvic outlet. Then hydrocephalus, where it is due to excessive head size, this will result in obstruction at the level of inlet. And tumors like neck masses or sacrococcygeal teratoma, this will result in mechanical obstruction. So the abnormality of the pelvis, although contraction are often strong in obstructed labor, poor coordination may add to hypertonic uterine contractions, incoordinated uterine action, and ineffective pushing due to maternal exhaustion. Clinical features include labor pain for many hours without any progress, maternal exhaustion, dehydration, and restlessness, anxiety due to inability to bear pain, and neglected cases may present with ruptured uterus, shock, or even severe sepsis. Coming to the examination findings, there will be distended tender abdomen because of impending uterine rupture, Bandel's ring, that is a pathological retraction ring, which is a sign of obstructed labor, wherein one half of the uterus will contract, the other half remains non-contractile, and molding and large caput resulting in significant CPD, cervical edema due because of prolonged labor, high or unengaged fetal head resulting in mechanical obstruction, and absent or abnormal fetal heart rate resulting in fetal distress or even death of the fetus. Coming to the management, so whenever you are visualizing you are seeing an obstructive labor case, you have to make sure that the maternal stabilization, rapid diagnosis, and a timely decision makes regarding the delivery is vital. So the first thing is IV access with a large bore cannula because it prevents shock or correct dehydration. Then IV fluids like ringer lactate or normal saline to correct the impending electrolyte imbalance. Catheterization to empty bladder and assess urine output. Oxygen inhalation to improve the maternal and fetal oxygenation. Broad spectrum antibiotics to prevent or treat infection, and partograph assessment to confirm obstructed labor. So this is main for maternal stabilization. Coming to the definitive management, going for a cesarean section, this is the safest and the most common intervention, especially when fetus is alive, obstruction is diagnosed early, CPD is present, and malpresentation cannot be corrected. Instrumental delivery, though it is used very sparingly, only in selected cases, or indicated only in, when the obstruction is at the level of outlet and head is low and well engaged and there is no CPD. Usually it is done through vacuum extraction or forceps delivery. Coming to the other procedures used only when this fetus is dead and maternal safety is paramount in areas lacking surgical resources. These include craniotomy, decapacitation or evisceration. In craniotomy, in cases like hydrocephalus or dead in fetus, decapacitation where there is neglected shoulder presentation, evisceration where there is fetal abdominal masses are there. Coming to the fact, if the uterine has already ruptured, then go for immediate laparotomy, repair of the rupture if feasible, and subtotal or total hysterectomy in uncontrollable bleeding. Coming to the maternal immediate complications, uterine rupture resulting in excessive pressure and thinning of the lower uterine segment, postpartum hemorrhage resulting in atony, trauma and inversion, sepsis resulting in prolonged labor, intrauterine infection, shock due to hemorrhage or dehydration, and bladder or urethral injuries resulting in compression and necrosis. Coming to the long-term complications, this might include vesicovaginal or rectovaginal fistula, chronic pelvic pain, pelvic floor prolapse, stress urinary incontinence, and infertility due to uterine damage. The fetal complications include birth asphyxia due to prolonged compression of the fetal head, stillbirth due to late referral or maybe delay in decision making. This is why we make sure that decision making has to be paramount. Hypoxic ischemic encephalopathy in case of severe oxygen deprivation, and intracranial hemorrhage where there is excessive molding and trauma. Neonatal sepsis where there is prolonged rupture of membranes. Coming to the prevention part, in the antenatal time, early registration and regular ANC to identify any risk factors, screening for diabetes, anemia, pelvic adequacy, hypertension to prevent macrosomia and diagnose CPD, correction of malnourishment to reduce pelvic deformities, ultrasound to detect anomalies or malpresentation. This is to plan the delivery appropriately. Coming to prevention during the intrapartum time, skilled birth attendants at every delivery center, strict use of partograph, early identification of non-progression, and timely referral to higher centers with operative facilities to prevent any unforeseen complications. So the preventive part in health system measures include strengthening the transport, 24/7 ambulance services along with obstetric care, blood bank availability, training of staff in emergency drills. Community measures include education about danger signs, encouraging institutional deliveries, addressing childhood nutrition to prevent rickets and pelvic deformities. So to summarize, obstructive labor occurs when fetus cannot progress through the birth canal despite strong uterine contraction, usually because of mechanical barrier. The condition often arises during the active phase of the first stage or the second stage of labor. Its causes include abnormalities of maternal pelvis, soft tissue obstruction, fetal malposition and malpresentation, macrosomia, congenital anomalies like hydrocephalus. Clinically, the women presents with prolonged labor, severe exhaustion, dehydration, abdominal tenderness such as Bandel's ring, excessive molding, a large caput indicating impending danger. Without timely intervention, the obstructed labor may progress to uterine rupture, sepsis, postpartum hemorrhage and severe fetal hypoxia. Management requires prompt stabilization, increased IV fluids, bladder drainage, oxygen support, antibiotics, followed by a definitive intervention based on the cause and fetal condition, mostly cesarean section because it is the most safest and most common method. Instrumental delivery is reserved only for carefully selected cases with a low engaging head. Destructive operations like a craniotomy or decapacitation, evisceration are done only when fetus is dead and to save the life of the mother. Prevention is crucial and depends upon good antenatal care, assessment of pelvic adequacy, screening of malpositioning and malpresentation, use of partograph, skilled birth attendants and efficient referral system. So I hope you have learned from this presentation. Thank you for watching the presentation.